Thank you, Mr. Chair, and thank the witnesses for testifying today. Mr. Lyons, employees place a great deal of value on their health care benefits, but we know that as health care costs continue to rise, employers have less money to spend on wages. There have been numerous studies linking high health care costs to lower wage growth, making it critical for American families that employers do everything that they can to keep health costs down while maintaining access to higher care. Can you discuss what strategies have been most successful in your plan, how price transparency can help lower costs, and if it would be of benefit to the United States to change their tax code that was incorporated after World War II to have healthcare costs as a benefit rather than wage increases?
Thank you. Being on both sides of the collective bargaining table, this is a very important topic. The plan that most municipal employees are in New Jersey is called the Rec 10. It's $45,000 for family coverage now. My members are paying $15,000 of that, but the taxpayers are paying $30,000 of that. We also have a 2% wage cap in New Jersey. So when we had a 31% increase over the past 2 years, there was no wage increase because that had to come out of their checks as premium. So where we have been successful, some time ago, we implemented a reverse drug auction. And the state, the estimate, and once again, I wish I could give you real numbers, but they won't give me the data. So, but the estimates were $2.53 billion over 5 years that we saved. So that's one place we've been fairly successful. We had some abusive practices going on in the state. We were able to cap them. I think actually I regret voting for it right now because it was the insurers' way of forcing people into their network, and we were used as pawns in that. So, but that did save a significant amount of money, and there were articles in ProPublica. There were some pretty intense abuses going on in PTOT and chiropractic, but we've got that under control too. But that's probably the biggest successes. Quite frankly, we haven't had any successes in a few years. We're getting kicked around.
Thank you. Ms. Tripoli, Families USA has published a number of articles on rising healthcare costs and the role of consolidation and lack of federal action on policies such as site of service reform. A March 2020 MedPAC report highlighted a 30-year trend in increasing hospital consolidation, stating that in 2017, one single hospital system was responsible for 50% of discharges in most markets, and drew a link between hospital consolidation and higher prices for patients. In 2010, I warned about this very thing happening with the passage of the Affordable Care Act, actually before and after the passage, that it would lead to increased consolidation. Families USA has also published studies that claim hospital prices have increased roughly 31% since 2015, and that hospital consolidation costs the average American family $1,000 annually. What policy proposals, other than the lower cost, More Transparency Act, should Congress be considering to pump the brakes on consolidation, and do you expect consolidation trends to continue absent federal action?
Thank you for the question. I think absolutely we've seen a growing trend of consolidation dating back to the 1990s, I think, and even maybe before then. And so I think without federal action, without the oversight from the federal government and state regulators, I think we will in fact see the continued consolidation across the markets within the markets in the United States healthcare system. I think there are a number of solutions that Congress could be considering outside of price transparency and site neutral payment policy, but I think those two solutions in particular are so important for this moment. We have the Lower Cost, More Transparency Act, which of course has a limited site neutral provision for drug administration services. It's a foothold to a broader discussion that we need to have. We hope that the members of this committee and your colleagues in the Senate and other members of the House will have about a more comprehensive site neutral policy. At the end of the day, we need to be thinking about policies that are going to address the underlying broken incentives in the healthcare system that incentivize big hospital corporations, big healthcare corporations from consolidating, buying up more market power.
Thank you. I have just a few minutes, so Dr. Ippolito, if you could briefly address this. You've written recently about shortcomings in the No Surprises Act and have stated that there would be an advantage to eliminating the IDR process and replacing it with an explicit payment standard or a requirement that facility-based clinicians contract with the same insurance plans as the facility. Who do you believe should be responsible for determining the explicit payment standard? And would there be a reason to believe that requiring facility-based clinicians to contract with the same insurance plans as the facility would cause more burden for the physician?
A very brief answer is that my concerns with the current system is that it's generating tremendous administrative costs both to physicians and to insurers alike. In terms of who would set up the payment, that would be Congress. I know that wouldn't be an easy question, but that would be where it would fall. And the rest of it, perhaps I can answer in a question for the record in more detail.
If you could answer in more detail in writing, that would be
Absolutely.
very beneficial. Thank you. With that, I yield back my time.